Greetings everyone. You are watching Infovideopedia with me, Shilpi. Many philosophers pointed that nature is the best medicine. Nature's gifts, such as sunshine, fresh air, water, these are all priceless and extremely valuable. How about a good night's sleep or a genuine smile on someone's face? You cannot put a price tag on any of these, and they help us in our normal well being and overall being in a healthy state. However, sometimes we all fall sick, and medicines come into play to restore the normal balance of the body. In my previous videos, I have covered drug absorption. What are the different routes of drug administration? What is bioavailability? In this video, we will cover what is drug distribution and what is the clinical relevance of drug distribution, what is volume of distribution, and the factors that impact volume of distribution. So let's get started. Let's understand what is drug distribution and why it matters. What is drug distribution? In the previous video, we covered drug absorption, that is, the movement of the drug from the site of administration into the bloodstream. Now the drug is already in the bloodstream, and distribution refers to the transfer of the drug from the plasma into organs, tissues, interstitial fluids, and the intracellular compartment. Why should we study drug distribution? To be effective, many drugs must reach the site of action, that can be the target organ or the tissues at the right concentration. For example, if the site of action is liver, the drug needs to reach liver. If the site of action is brain or spinal cord, drug needs to be in these areas. If the site of action is cancer cell, the drug needs to be in the tumor microenvironment. Also, if the drug ends up in non-target tissues or too much in one tissue, it can cause toxicity or off-target effects. To summarize, drug distribution determines how much of a drug reaches where it's needed, shaping both the effectiveness and the safety profile of the drug. Also, in this video, we will cover volume of distribution, and the single most utility of volume of distribution is to calculate the loading dose of a drug. Now, there are several factors that can influence drug distribution throughout the body, and we will cover all of them. These include the blood flow to different organs, tissue permeability and the architecture of the capillaries, and also the intrinsic property of the drug itself. Not all organs in the body receive the blood at the same rate. Blood flows varies on the organ's physiological needs. Organs like lung, liver, brain, heart, kidney, they are metabolically more active and they need a constant supply of oxygen and nutrients to function properly, and hence they have a higher blood flow. A higher blood flow may result in a faster drug distribution. Now, if the body enters in a state of shock, that is, it can be rapid blood loss following an accident, or a heart attack, or due to septic shock, this can lead to decreased or impaired blood flow to the tissues and potentially reduce drug distribution. Conversely, conditions like exercise, fever, inflammation can increase the local blood flow and thereby enhancing drug distribution to the affected tissues. On the other hand, tissues such as muscles at rest, skin, bone, they have much slower blood flow because these organs are metabolically less active at baseline, and the drug distribution happens more gradually in these organs. Another factor is capillary permeability, that is the architecture of the capillaries. Now, the architecture of the capillary can be different in different organs. For example, on the left, you see the continuous or the non-fenestrated capillaries in the brain. These are the cross-section of the capillaries. Inside is the lumen, and these are the endothelial cells, and this is the nucleus. In the continuous non-fenestrated capillaries, these have tight junctions. For example, the blood-brain barrier. And drugs really cannot cross these blood-brain barriers easily. The second is the continuous or the fenestrated capillaries. They are found in tissues like kidney, and they have small pores called fenestrations, and they have increased permeability. And on the right are sinusoidal capillaries or discontinuous capillaries, and these are leaky capillaries. They are present in organs like liver and spleen, and the drugs can pass more easily through these capillaries. And hence it's not just one factor, it's really a combination of many factors that decides drug distribution. We covered the biological properties that can impact drug distribution. Now let's talk about the drug intrinsic properties. The drug molecules can be acidic or basic, they can be lipophilic or hydrophilic, charged or uncharged, and this can impact drug distribution. Acidic drugs prefer to bind albumin and stay in plasma. Basic drugs, on the other hand, they interact with the negatively charged head groups and allow higher tissue partitioning. Lipophilic drugs, that means they are lipid-loving, they can get dissolved in lipid molecules such as oils and fat, and they can partition more. Hydrophilic drugs, they tend to stay more in the plasma. Now, let's come to a very important concept, that is volume of distribution. Volume of distribution is a theoretical or an apparent volume of distribution, and it helps us to estimate how a drug distributes or spreads from the blood plasma into the body tissues. Volume of distribution is a proportionality constant that relates the total amount of drug in the body to the concentration of the drug measured in the plasma at a given time. And the formula for VD, that is volume of distribution, is the amount of drug in the body divided by plasma drug concentration. To start with, the amount of drug in the body is actually the dose. And to put it in very simple terms, if the drug distributes widely, it leaves the blood, it leaves the plasma, and it distributes, it has a higher volume of distribution. But if the drug prefers to stay in the plasma and distributes less, it has a lower volume of distribution. Let's talk about it a little more. Unionized. Unionized means uncharged. Weak, basic. Lipophilic, small molecules, they have wider distribution. So if they are uncharged, weakly basic, and lipid-loving, they would have a wider distribution, and the drug would distribute more into the interstitial and the intracellular compartments. Now, more drug is in the tissue and less is in the plasma. The concentration of the drug in the plasma decreases. And according to the formula, volume of distribution is dose divided by plasma concentration. If the denominator decreases, then the volume of distribution will be high. You got it. So, lower plasma concentration means higher volume of distribution. Let's take the opposite case. Now, the drug is acidic, that means it has the tendency to bind the plasma albumin more. It's hydrophilic, means it's water-loving. Or it's a large molecule, then it would have a limited distribution into the tissues. Now, more drug is in the plasma, that is, the concentration of drug in the plasma is high. And if your denominator is high, the volume of distribution will be low. You got it. So, higher plasma concentration means lower volume of distribution. Let's take a recap of the drug intrinsic properties that play a role in volume of distribution. Lipophilic lipid-loving drugs tend to cross the bilayer and partition to the fat. They tend to have a higher volume of distribution. Molecular size, large or biologics, they are restricted more to the plasma or to the extracellular fluid, and hence their volume of distribution tends to be lower. Albumin. So, if the drug has a high tendency to bind to plasma proteins such as albumin, it tends to restrict more in the plasma and volume of distribution would be low. If the tissue has high tissue binding capacity, then the volume of distribution would be higher. Unionized, that is uncharged fractions, cross the membrane more easily, and weak bases also accumulate intracellularly. Please note that it's not just one factor, it's a combination of many factors that influence drug distribution. There are some thumb rules when we look at volume of distribution, like what is small volume of distribution compared to a larger volume of distribution. So typically, if the drug has volume of distribution, say 3 to 5 liters, it has a low volume of distribution. That is, the drug is largely confined in the plasma. Intermediate volume of distribution is around 10 to 20 liters. That means the drug distributes into the extracellular fluid, but it may have a limited entry into the cell. Large volume of distribution means the drug extensively, it can reach the different tissues, and overall low plasma concentrations. And some examples include low volume of distribution, example warfarin. High volume of distribution, example chloroquine, the malaria drug. This table compares the distribution properties of different class of drugs. This includes small molecules, antisense oligonucleotides, siRNA, and antibody-based therapeutics. Small molecules are generally low molecular weight. They are often neutral or weakly charged, and hence they can cross the membrane easily. As a result, they usually show moderate to high volume of distribution. Talking about antisense oligonucleotides and siRNA-based drugs, they are much larger compared to small molecules, and they have a net negative charge. Due to these properties, they have poor membrane permeability and require delivery systems or uptake mechanisms. Many times these drugs, siRNA, are conjugated, such as GalNAc conjugation, so that it can facilitate the entry into the hepatocytes. Because hepatocytes have ASGPR receptors, and the GalNAc on these siRNA can bind the receptors, and it results in intracellular endocytosis of these siRNA molecules. Antibodies, on the other hand, they are very large, around 150 kilodaltons, and they are mostly confined to the plasma and extracellular fluid, and they have low volume of distribution. Their distribution is largely restricted to the vascular and the interstitial spaces because of their size. These are some of the real-life examples of the drugs. For example, aspirin and warfarin are small molecule-based drugs. Spinraza for spinal muscular atrophy is a classic example for an antisense oligonucleotide-based drug. Patisiran was the first siRNA that was approved. This was an siRNA encapsulated in a lipid nanoparticle. And for antibody-based therapeutics, we see a lot of examples in the immuno-oncology space. For example, atezolizumab, durvalumab, or trastuzumab. This diagram illustrates the drug distribution following an intravenous injection. This is an IV bolus. All the drug is administered at the same time. The drug molecule can exist as a free form, or it can exist as a bound form with albumin. And only the unbound fraction is able to leave the blood and move to the extravascular compartments. The drug distributes into the systemic extravascular fluid, and then depending on the drug properties, it can move into the intracellular fluid. The movement of the drug between the compartments is typically bidirectional and is governed by the rate constant. Let's look at this PK profile. This is concentration of the drug versus time. As seen in the PK graph, immediately after dosing, the concentration peaks and it reaches a Cmax. The concentration of the drug then declines as the drug distributes into the tissues. That's the distribution phase, followed by a slow decline due to the elimination phase. This diagram illustrates the intrathecal route of administration, where the drug is injected directly into the cerebrospinal fluid, that's the CSF. This route bypasses the blood-brain barrier and it allows the rapid and concentrated drug delivery into the brain and the spinal cord. As shown in the PK graph, the drug concentration rises in the CSF. It reaches a peak value called Cmax at an earlier time point, Tmax. The concentration then falls as the drug gets distributed into the brain and spinal cord, or it gets cleared from the CSF. Some of the drug also distributes to the plasma compartment, and then it moves to the systemic extravascular fluid and the intracellular fluid depending on the property of the drug. In the plasma, the PK profile shows a delayed and a lower Cmax compared to the CSF. This illustrates how the route of administration and the intercompartmental transfer influences both the timing and the extent of drug exposure in the brain and the peripheral organ. One classic example is Spinraza, an antisense oligonucleotide for spinal muscular atrophy, and it's delivered intrathecally. Let's understand the clinical relevance of volume of distribution. Here are some formulas and it's good to go over them. Loading dose is the target plasma concentration times volume of distribution divided by bioavailability. Bioavailability for intravenous is 1. Half-life relationship, half-life is 0.693 times volume of distribution divided by clearance, which means if the clearance is same, if the drug has a higher volume of distribution, it might take longer to clear that drug. The half-life is longer. Also, there are population differences that do impact the volume of distribution. For example, in obese population, the volume of distribution might be higher for lipophilic drugs. On the other hand, if the patients have edema, that's water retention, the volume of distribution of hydrophilic drugs might be higher. Chronic kidney disease impacts the drug distribution because chronic kidney disease can cause low blood albumin. The normal function of the kidney is to filter and then efficiently reabsorb albumin, returning it into the circulation. In chronic kidney disease, this function is impaired, leading to low blood albumin and reduced binding of the albumin-bound drugs because more albumin gets eliminated in the urine. And hence, when the patient has a chronic kidney disease, the albumin concentration is lower and there is increased apparent volume of distribution. Also for liver diseases can lead to inadequate synthesis of albumin and potentially increased volume of distribution. And hence the clinicians are careful when they deliver drugs to these patients. Biodistribution is an important concept, and it comes especially when we are in the drug development phase. We look at the biodistribution of the drug and the molecules. Biodistribution is the study of how a drug or a therapeutic agent moves throughout the body after administration, measuring how much it gets into various organs and tissues over the time, and this impacts the efficacy and safety of the drug. Many times these molecules are radio-labeled or fluorescently labeled so that we can track them. We can also quantify these drugs by using different bioanalytical methods. We can quantify these drugs and understand their biodistribution. Let's summarize what we learned today. Distribution, that is, drug distribution, is driven by factors such as perfusion, that's the blood flow, permeability, the architecture of the capillaries matter, and the drug properties. Is the drug lipophilic? Size, ionization, binding affinity to plasma protein, everything matters, and it's really not one factor, but it's a combination of factors that help determine the drug distribution. Volume of distribution summarizes distribution relative to plasma concentration. New therapeutic modalities like antisense oligonucleotides and siRNA have unique distribution challenges based on their chemical properties. And these are the formulas for loading dose and half-life. Now, here's a practice question. Read the question, take a pause, and answer it. A drug is administered intravenously with the following properties. Volume of distribution is 10 liters. Desired plasma concentration is 10 milligrams per liter. Bioavailability, it's intravenous, so it's 1. What is the loading dose in milligram required to rapidly achieve the target plasma concentration? Pause the video and answer this. Okay, so this is the formula for the loading dose. That is the target plasma concentration times volume of distribution divided by bioavailability. In this case, F is 1. So it's really, the answer you get is 100 milligrams. Liters and liters cancel. Be careful of the units. It's very important. So the answer here is C, 100 milligrams. This is an AI-generated video. I gave specific prompts to generate this video. Let's enjoy.
Ever wondered why the same dose of a drug can act differently in two people? It's all about how drugs move, the distribution. Today, I'll explain distribution and the volume of distribution, VD. Where does a drug go once it's in your bloodstream? Not all organs are equal. The liver, the lungs, skin, fat. High blood flow organs get drugs fast. Low flow organs take longer. It's not just blood flow, architecture matters. Capillaries, tiny blood vessels. Liver capillaries are leaky. Drugs pass easily. Brain, the blood-brain barrier is restrictive. Drug properties matter too. Lipophilic drugs, oil-like, enter tissues and fat. Water-soluble drugs tend to stay in the bloodstream. Big molecules often stay in the blood. Small molecules distribute widely through tissues. Charge matters. Acids and bases. Protein binding keeps drugs in plasma, reducing their free movement. How do we measure it? Volume of distribution, VD. Formula, VD equals sign amount of drug in the body divided by plasma concentration. Or simply, VD equals sign dose, plasma concentration. Low VD means most of the drug stays in the blood. High VD means the drug hides out in tissues all over the body. Why it matters. Doctors use VD to set the right dose. It also guides overdose treatment. Remove from blood or from tissues? Next time you take medicine, remember, there's a science to where it ends up. That's drug distribution and volume of distribution, making sure medicine goes where it's needed most.
I love this video. Hope you enjoyed it too. These are my references. And these are the acknowledgements. For any question, please feel free to reach me at my email drshilpimahachan@gmail.com, and please subscribe. Thank you. See you next time. Bye.